Gastroenteritis. Key points. In a child with red flag features or a child with vomiting without diarrhea, consider alternative diagnoses. Most children do not require investigations, including stool testing. Whenever possible, the enteral route, oral or nasogastric, should be used for rehydration. Background. Gastroenteritis is a common childhood illness that causes vomiting, diarrhea and fever, often in sporadic seasonal outbreaks. The cause may be viral or bacterial, but knowing the cause rarely changes management. It is important to assess the degree of blank, as this influences route and rate of rehydration. Assessment blank. History. Although vomiting may precede diarrhea in the first 24-48 hours of gastroenteritis, in a vomiting child without diarrhea other causes must be considered. Age under 6 months. Fever, infectious contact, recent fluid intake, volume and type compared to usual, including hyper or hypotonic fluids. Volume and frequency of vomit and stool. Bilious vomiting. Blood or mucus in the stool. This suggests significant inflammation that may occur with bacterial infection or inflammatory bowel conditions. Urine output. Crampy. Blank. Past GI/surgical history, e.g. short gut, Hirschsprungs, ileostomy, or complex medical history, e.g. renal, cardiac disease. History of blank. And/or fortification of feeds. Recurrent presentations for similar symptoms. Examination. Many children will have a normal examination, or generalized abdominal tenderness. Pallor, irritability, altered conscious state, decreased activity level. Signs of shock, blank. Blank. Focal abdominal tenderness. Guarding. Significant distension. Absent or high-pitched bowel sounds. Degree of dehydration. Weight, bare in infants. C. Blank. Management. Investigations. For most children with presumed and uncomplicated gastroenteritis, no investigation are required. Blood sugar and electrolyte measurement. All children requiring blank should have serum, electrolytes and glucose checked before commencing the infusion, typically when the 4 is placed, and again within 24 hours if 4. Therapy is to continue. Blood sugar, ketones, and electrolyte measurement may be required for children with severe dehydration, profuse or prolonged losses, or altered conscious state. Inappropriate hypertonic fluid administration, e.g. sports drinks, or prolonged hypotonic fluid administration, e.g. diluted formula or water-only rehydration. Complex medical or surgical comorbidities or diuretic use. Stool culture or not recommended. Except in unwell children or young infants with bloody diarrhea. Blank. Blank. With prolonged symptoms, and GT 10 days. Immunocompromised patients with fever. Treatment. Many cases are self-limiting and only require encouragement of fluid intake and monitoring of hydration. Failure of initial management should prompt reconsideration of the diagnosis and management plan. Oral rehydration. Aim for 10 ml/kg/hr of oral rehydration solution, e.g. Gastrolite. In children who are refusing ORS, diluted apple juice in 1:1 ratio with water can be offered, but is not appropriate for prolonged use, as does not contain any electrolytes. Stop any feed fortification, e.g. extra scoops of formula or polyjowletin. If breastfed, continue breastfeeding, but more often, or with additional ORS supplementation, to maintain hydration. Once rehydrated, a normal diet can be recommenced. Temporary lactose restriction should not routinely be advised, but if stool frequency increases it may be considered. If oral rehydration fails and the child is greater than or equal to 5% dehydrated, or if there are significant ongoing losses, rapid or slow NG rehydration may be blank. Blank. 4. Rehydration may be preferred in older children if NG is not tolerated or is not appropriate. Refer to blank. 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 Medications. Children and infants and GT 6 months with nausea or vomiting may be given ondansetron and can assist with oral or enteral rehydration. Suggested ondansetron doses: oral. Weight: 8 to 15 kilograms. Dose: 2 milligrams. Weight: 15 to 30 kilograms. Dose: 4 milligrams. Weight: and GT 30 kg. Dose: 6 to 8 milligrams. Other antiemetics are not routinely recommended due to side effects. Response to antiemetics does not confer diagnosis. Antidiarrheal medications are not recommended. Probiotics are not effective at reducing symptoms of acute gastroenteritis. Antibiotics should not be used for uncomplicated diarrheal illness. Antibiotics should be reserved for treatment of enteritis-associated sepsis or specific bacterial pathogens in selected cases, e.g. Salmonella, non-typhoid, Salmonella typhi. Non-typhoidal salmonella in patients under 3 months, immunocompromised, or with sepsis, or with severe blank. Non-typhoidal salmonella in patients under. Consider consultation with local pediatric team when initial rehydration unsuccessful and/or significant ongoing losses. Complex comorbidities. Electrolyte abnormalities. Diagnosis is unclear. Red flag features. Consider transfer when severe electrolyte disturbance. Shock requiring more than 40 ml/kg in fluid boluses. Blank. Consider discharge when tolerating oral intake and nil/mild dehydration.